a 2-minute short video on Universal Health Coverage Day by WHO Director General Margaret Chan. It seems that we have some practical challenges in showing the video right now. I suggest that we will send you the link and try to present it and share it again at the end of the call, and we will move back to the panel debate in itself, if that is okay with you, Liz. So, as you have seen in the invitation, we want to kick off the panel discussion of today by introducing a lead economist of the World Bank, Mr. Daniel Kotlier, who is the manager of the Universal Health Coverage Support Program, known as UNICO, and the editor of the Universal Health Coverage Studies series of the World Bank Group. And these UHC studies series published 24 country case studies analyzing how policymakers around the world are implementing universal health coverage. And his most recent publication is a book called Going Universal: How 24 Developing Countries Are Implementing UHC Reforms from the Bottom Up. And it's co-authored with 4 World Bank colleagues, and there was also a Lancet article around overcoming social segregation in healthcare in Latin America. Mr. Kotlier, I had the privilege of being present at the launch of the book and the presentation of the book at the United Nations General Assembly last September. And based on that presentation, we are quite keen to hear from the evidence that you have gathered, what are key lessons that we could take on board here in Europe when considering support to countries that are implementing universal health coverage. So I hand over to you for the first keynote speech.
Good morning, good afternoon, good evening, depending on where you are. I'm very. Can you hear me?
Yes, you sound great.
Yes, we can.
Okay. Very happy to join this webinar today, especially given the fact that we're also celebrating Global UHC Day. And I think the message I'm going to present today very much coincides with the message of Global UHC Day, which basically is it can be done and it can be done well. I will not presume to comment about the role of European governments. What I'm going to do is simply share the results from our 24 studies to invite a discussion from the European experts about what that role might be. So, as Tim said, this is a synthesis of 24 individual case studies. The synthesis itself was launched a couple of months ago. The launch coincided with the launch of the SDGs and of SDG 3.8. Can we have the next one? Next slide, please. So the single simplest message coming from the 24 countries is that there is this movement, and if you look at the movement as a whole, you find first that the UHC programs that are being implemented are new. Most of them were implemented in the last 10 years. This is a new wave in terms of what's happening in global health in developing countries. Second is that the UHC programs are massive. In the 24 countries we studied, they are covering already 2.4 billion people, which is almost a third of the world's population. But perhaps the most exciting finding is that in addition of being new and massive, these programs aim to be transformational. They're changing the way health systems work. And the focus of our case studies was on what we call bottom-up programs, programs that start with or emphasize inclusion of the poor. And health systems are changing for the better, in particular for these populations. Next, please. So the approach we took for the case studies is we looked at 5 aspects of the how. The studies are not about the impact. The studies are about getting a careful, detailed understanding of how the programs are operating. We started with a UHCQ, and so we decided to carefully look at how these programs are covering people, how they're expanding benefits, how they are reducing cost sharing and fees. We then realized that in many of the countries, in addition to these 3 aspects, countries are also doing very important things in the area of supply. And so we also looked at how countries are improving supply. Finally, we found that there's a lot of space, a lot of slack in many of these systems, and that countries are trying to reduce that slack by strengthening accountability. So the 5th area of inquiry of the study was to understand how they are strengthening accountability. I'll come back to this structure as I tell you a little bit about the results. Next, please. These are the 24 countries, and as you can see, they cover all developing regions in the world, and it includes a variety of countries in terms of income levels. There's low income, upper middle income. There's countries with a pre-transitional demography, countries with a post-transitional demography. One thing perhaps they all have in common, or had in common in the first 15 years of this millennium, was that these countries were all high growth countries. And this may be something to bear in mind. Next, please. So these are the programs themselves. The way this study operated was that we analyzed how the health system as a whole operates. But then in order to really get granular, we decided to look in particular at the details of that program, which had in the last decade done most, or made the greatest effort to expand coverage in a way that's inclusive of the poor. Often there's been some discussion about this methodology, and perhaps what's important to bear in mind is that when you're studying health systems in developed countries, usually what you find is that after many decades of having a fragmented system, they have managed to unify, to catalyze some kind of a framework for the country. And so when you're doing a health in transition type of study, you can look at the health system as a whole because there's one. In many of these countries, there are several health systems or sub-health systems that are coexisting. And so we needed, in order to become granular, we needed to go in some detail into one of them. That's how we chose. As you can see, these programs, most of them were created after the year 2000. Coverage was, as I described before, massive, both in terms of numbers and in terms of percentages. Very important, one of the senses in which these programs are massive is that these are not pilots. All of these are, even the programs that in terms of absolute numbers are relatively small, are programs that are operating at scale. That's an important characteristic of the movement. Next slide, please. So in terms of the 5 categories I described at the beginning, we find that countries are coinciding in the use of some policies. And so we're calling that areas of policy convergence. At the same time, they are, of course, diverging in some of the policies they apply. So let me describe where they're converging and where they are diverging. In terms of covering people, countries are leaving behind the traditional system of operating in an impersonal manner. Health systems are evolving in a way that's increasingly personalized. This is both for financial, organizational, and for clinical reasons. But in any case, one of the features that we find in most of the programs is that the process of identification of people is important for the development of the program. This involves the use of citizen ID systems. It involves the use of enrollment. It involves the use of targeting in the case of programs that are targeted. A second area of policy convergence is what is a practically universal agreement now in these 24 countries, that poor people should not pay for health. This agreement is based on the recognition that paying for health might restrict their access to health system and will impoverish them. So with regards to this particular population, to the poor, the consensus is now almost overwhelming. This, of course, then has implications in terms of the need to be able to identify people, which is linked to the previous feature I described. In terms of expanding benefits, most of the countries we studied are providing coverage that goes beyond the essential MDG intervention package. We did find a few where the essence of the program was restricted to the MDG interventions, but in most of the countries, they feel that that essential package has already been covered, or in order to cover it more appropriately, needs to become broader. So broadening the benefit package is a very common feature. Second, just as there's an effort in terms of identifying people in the covering people dimension. In the expanding benefits dimension, there is now a consensus that it's not enough to promise all types of benefits. Most of the countries are promising explicit benefits. So the effort of making the benefits, the benefit package explicit is very common through the 24 countries. This comes accompanied with the use of new contracts and output-based payment system for those benefits that are made explicit. In terms of managing money, this is perhaps an area where there's often some, or where we had some confusion before we started the research. What we found is that in most countries, the UHC programs are trying to leverage rather than trying to replace the Ministry of Health. Programs, for example, that create a purchaser. In most of the countries, they're not trying to create a purchaser that's independent or that's going to duplicate some of the functions of the public providers. Instead, in all cases, the design involves efforts to make the Ministry of Health, the public providers of the Ministry of Health, operate better. In 18 of the 24 countries, this involves the creation of some kind of a purchasing role. And the implication of this is that now in these countries, public providers are financed through a combination of demand and supply side subsidies. This brings new challenges to implementation, of course. In terms of improving supply, we find that almost everywhere, the new efforts involve more flexibility in public hiring and in the management of public providers. The need for some flexibility in the management of cash at the local level is recognized almost universally, and is a big problem and a problem of tension with ministries of finance in most of the countries we studied. The use of private providers was found in half of the UHC programs we examined. This is more than what the traditional use of private providers did, but it's in no sense a general feature. We also found that accreditation systems are ubiquitous. So in terms of strengthening accountability, perhaps one could summarize by saying that there's three types of efforts that are very common. What we found most common of all was the use of arm's length delegation with output-based financing. In other words, it's the notion that a split between some form of purchasing, at least for some part of the product, and provision is something that may strengthen accountability. We didn't find, well, we found that many countries are now doing this. A second area where efforts to strengthen accountability are everywhere is that there's a lot more data collection. Partly this is a result of the use of the new systems, and particularly when there is this purchaser-provider split, there tends to be a lot more data that's being collected. This sounds promising, but I'll come back to this in a moment. And the third area which we found that is taking place in many, but not in all countries, are efforts to empower citizens in their relation with specific providers and with the health system as a whole. So these are the areas of convergence, but there are, of course, significant areas of divergence. Next slide, please. So the first of the policy choices we emphasize is that countries, of course, need to decide if they will be following the bottom-up approach or if they will continue to rely, as most of these countries did before this millennium, in a trickle-down approach. Basically, the finding there was that at the turn of the millennium, if you looked at public expenditures in health, they were very much, there was an almost universal pattern of pro-rich spending. And the whole apparatus of the UHC programs that I've been describing was partly an attempt to turn that around. But not every country has decided to use the bottom-up approach. So that's very much a first decision. The second is that some countries are emphasizing supply-side reforms, whereas other countries have gone for the demand-side programs. We haven't really found any country that was able to do both things simultaneously in a deep and systematic manner. So it's unclear why that is the case, perhaps. But anyway. Second area of policy choice that I wanted to emphasize relates to covering the non-poor informal population. While, as I explained before, in all these countries, there is now a very strong consensus that the poor populations should not pay for health care. There is a huge debate about whether the non-poor informal populations should pay for health care or not. And so countries are taking diverse paths with regards to this. The debate between contributory or non-contributory paths has nothing to do with how to finance the poor, but it has everything to do with how to finance the non-poor informal population. Linked with this is the link between the UHC programs and the social health insurance agencies. In some countries, the public purchaser is embedded in social health insurance. In other countries, it is autonomous. We find that this often coincides with the decision of having a contributory or a non-contributory form of organization for the non-poor in the informal sector. Also, we found that this has to do with decisions about redistribution, whether redistribution should happen within a single agency or across agencies. And by the way, I should say, we found that being within a single agency does not in any way guarantee a stronger redistributive policy in favor of the poor than if you have them in separate agencies. Next big policy choice is what benefits to expand next. None of these countries are debating what is the first package of benefits that needs to be provided. Everybody's already providing that. The big discussion is how do we expand what we're already providing? And some countries are choosing to go for inpatient, others for specialists, others for basic drugs, for expensive drugs, for high-cost tertiary services. We found very little in terms of rationale or explanation or cost effectiveness in terms of the choice. A lot of the choice seems to be fundamentally based on political economy influences. And finally, a policy choice that's important is for those countries that are using the private sector, whether the private sector is meant to complement or is it meant to compete with public providers. The whole notion that a fair a level playing field is needed assumes that the role of the private sector is one of competition with public providers. Some countries perhaps are trying to do that and are trying to use competition as a way to increase the effectiveness or the efficiency of providers, both public and private. But other countries use the private sector to complement specific niches and not to compete with the public provider. Next, please. So there's many benefits, many potential benefits in all these programs, but there's also potential risks. And there's three that perhaps need to be highlighted and that perhaps are areas where European governments can help these countries. The first risk is brought by the increased complexity of these programs compared with the traditional health systems, where basically public providers operated simply as government departments. The new forms of organization are much more complex, and the complexity is both technical but also political. Second area of risk is that many of these programs are based on promises, on explicit promises. There's an explicit promises that a certain population will be covered. There's an explicit promise that a certain benefit package will be provided. There's often even an explicit promise that certain health outcomes will be achieved. And what we find is disappointing in particularly two areas. The first is that most countries that promise a benefit package seem to be implicitly rationing this package. In other words, many people needing some of the promised benefits don't have access to them. So that's a big broken promise. A second broken promise is that despite the fact that there is this huge new wealth in terms of microdata in many of these systems, there's a very insufficient use of these data. Monitoring and reporting are not very strong in many of the countries we examine. And the third area to be emphasized, of course, is fiscal sustainability. And we found that, in particular, fiscal sustainability is problematic where there's over-promising of benefits, where a very generous package has been promised. The risk, the fiscal risk, is not immediate because there's implicit rationing. But as accountability mechanisms are strengthened, as citizens are empowered to effectively demand what was promised to them, then the risk of fiscal sustainability may appear. Next, please. So in terms of mitigating those, the fiscal risks in particular, there seems to be three things that are important. The first is countries need to set clear priorities. And particularly since the consensus is to prioritize the use of fiscal subsidies for the poorest, perhaps there needs to be a little more work in some countries in ensuring that that is effectively happening. And this particularly takes two forms in terms of prioritization. As I explained before, countries need to make decisions about how to prioritize the use of fiscal subsidies by directing them to a certain population and by restricting them to a certain benefit package which is made explicit. Our impression is that against what was believed 20 years ago, the tools to target populations have now improved faster than the tools to effectively prioritize benefit packages. Second point is that in terms of mitigating fiscal risks has to do with making sure that the additional funds are used to complement and help public health services to become more efficient. Those of you who are familiar with the process in Georgia or the process in India with RSBY will note that this area of tension was present there. Is this program something that is going to be parallel to the Ministry of Health and to the private providers, to the public providers, or is it something that will be focused on making them work better? And finally, there's a need to set realistic targets. Countries, as I mentioned at the beginning, some have the range of per capita incomes in the countries we looked at was from 1 to 8 or 10. So what the richer countries among the developing countries can do, sometimes the poorer countries cannot do. And let me finish with one slide that illustrates this point. Next, please. So these are most of our countries, and they're ranked by the size of the informal sector as a proportion of the total population. And frankly, we didn't expect to find this pattern, but I think it's very strong. Basically, all the countries that have an informal sector that's larger than the median or the average have not been able to cover the informal sector. And if you look at all the countries that have a smaller informal sector than the median or the average, they all have made much more progress in terms of covering the non-poor in the informal sector. What exactly is the message out of this is something I leave for the discussion. Final slide, please. So I think the big message is countries can realize UHC in a fiscally sustainable way. There are, however, some risks, and I think there's a role for European governments in helping countries monitor and mitigate those risks. Thank you very much.
Thank you, Daniel, for a great presentation, short but very complete, and I am sure there are many that are keen to ask questions. I will now like to move on and keep the questions to the panelists, but clearly you have demonstrated that there is evidence that universal health coverage is political. It is about policy choices, including the risks. And the last point that you had mentioned is linking the progressive realizations to the economic growth. And we could ask us whether there is a policy choice also at the global level towards European governments, European institutions, on how the international community is to complement countries on their realization. I am quickly looking around whether there's any questions or clarifications from the panelists. If not so, then I would like to start and introduce the three panelists quickly before handing over the floor to the first speaker. So, part of the panel we have three guests. We have Miss Natasha Gomez with us from Luxembourg. She is the advisor for global health and multilateral affairs at the Director for Development Cooperation at Luxembourg Ministry of Foreign Affairs. She has been working in international development for over 10 years and handles the Luxembourg relations with health-related UN and other agencies, and represents Luxembourg at boards of different organizations such as Global Fund, UNAIDS, and Gavi. And I have asked Ms. Gomez in particular to share with us more about an existing partnership between Luxembourg, the European Commission, and the World Health Organization. But firstly, let me now also introduce our second speaker sitting next to me here in Brussels office, Dr. Christopher Knaat. Welcome. Principal Administrator at the European Commission in the DG International Cooperation and Development, the Health Unit. Mr. Knaat has been active in German and European NGOs promoting access to medicines, is a doctor, had worked also in the Heidelberg Institute for Tropical Hygiene and Public Health, and has been working in development cooperation of the European Commission as EU official with a special focus on health financing, universal coverage, access to medicines, and fragile countries. Welcome. And last but not least, we have on our panel Mr. Jean-Olivier Schmidt, who is heading the Competence Center Health and Social Protection at GIZ, the Agency for Technical Assistance in Germany, who has over 10 years also of working experience at GIZ, GTZ at headquarters and country level. He headed programs in Bangladesh on health, nutrition, population sectors, and in India, has worked as technical advisors in health programs across Africa. He has particular interest on health financing and universal health coverage. So welcome to all three panelists, in addition to Mr. Daniel Kotlier. And I would like to start with Ms. Gomez. Welcome. As I mentioned, we know that Luxembourg, European Commission, WHO, has its own experience of supporting countries on the realization or the implementation of universal health coverage. I do not know whether the countries overlap with those that were presented and studied upon by the World Bank, but I would be quite keen to hear from you whether you could share some of lessons learned from that partnerships on the rollout of universal health coverage, and whether you could reflect on the role of Europe, both the Commission with you as a member state, on universal health coverage. The floor is yours.
Thank you very much, Tim, and hello everybody. It's a pleasure to be with you today. So before I go into my presentation, let me quickly clarify. The two of our 20 countries that overlap with the World Bank study, which is Tunisia and Vietnam. Other than that, you will see quite a few similarities along the way. So I'm going to present to you our approach to universal health coverage, illustrated with the example of the EU-Luxembourg WHO Universal Health Coverage Partnership, which is subtitled Supporting Policy Dialogue on National Health Policy Strategies and Plans in 20 Countries. Next slide, please. So the partnership started in 2012 between the EU and WHO, first in 7 countries. It was extended to an additional 7 countries in 2013, which is also when Luxembourg joined, because we found this new concept, this new way of working very interesting. We were also in the process of rethinking our own priorities in global health and developing our new global health sector strategy, which identified UHC as its clear goal. So it was very much in line with that. You can see the countries listed on the screen. So at this stage, it's 14 countries supported by the European Union, and now 6 countries supported by Luxembourg. We originally started with only our 5 partner countries in Africa, and now in August this year we've added Laos, because it made a lot of sense given their health sector reform, and it is also very complementary with our bilateral program there. Next slide, please. I think we're all familiar with the definition of universal health coverage. I mean, ensuring equitable access of all people to health services that are of good quality and without running into financial damage. Equitable access is about populations. It's very often, as we've also heard from the World Bank, the poorest and the most vulnerable that are often left behind and that do need to be prioritized in these efforts, where benefits, services, etc. need to be actually tailored to the specific populations. We need to make sure that access in all its forms is guaranteed. This includes financial coverage, the availability of services, infrastructure, health personnel, but also geographical access, stigma and discrimination. There are just a very large variety of issues to consider. I've mentioned geographical. I mean, we all know that particularly rural areas often face challenges and lack the necessary infrastructure and personnel. And all of these go hand in hand. We know that, I think this has come out in a number of studies, and we see it in the countries in the partnership as well, that mere financial risk protection or health insurance will not automatically increase coverage if services are not available or if they are not of an adequate quality. And on the other hand, you know, if quality services are available but people cannot afford them, we also have a problem. So we need to we need to approach this from all angles. I mean, for Luxembourg, it's very clear the right to health is a fundamental human right, and nothing addresses or covers this right to health like UHC does. Luxembourg goes a little bit further in the financial risk protection aspect. We actually go beyond this, including comprehensive and equitable social protection systems as an integral element of UHC. These systems obviously go beyond mere financial risk protection and health insurance schemes. They also go beyond the health sector, but for us, UHC and social protection somewhat go hand in hand. Finally, of course, the financing and costing is an important aspect of this, and we've heard this time and time again. So we need to ensure that health systems are fully and sustainably funded, and obviously the mobilization of domestic resources, prioritization of national budgets. I mean, we've talked about this. These are all very familiar issues. Next slide, please. So, as said, the partnership that the EU-Luxembourg WHO UHC partnership focuses on policy dialogue. Why policy dialogue? Well, the ultimate goal is to develop and implement solid, comprehensive and equitable national health policies, strategies and plans It's done through engaging a large variety of stakeholders in iterative process, which allows evidence-based and informed decision-making. I mean, the World Bank report just has presented examples of countries using bottom-up approach in UHC, both supply-side driven and demand-side driven, and prioritizing key components and or populations. This bottom-up approach has also come into play in some of the countries of the UHC partnership, has insurance schemes covering the poor and vulnerable. These are key entry points in policy dialogue in a number of countries. But like in the study presented, they're starting points and stepping stones to then eventually go further towards true universal health coverage. Policy dialogue we see as key, because without the proper political commitment and overarching policies and strategies in place, there cannot really be a sustainable response. UHC is made up of a large variety of activities covering the whole spectrum of the health system, and these need to be brought together under one umbrella, which in this case is the National Health Sector Policy or Strategy or Plan. Clearly monitoring and evaluation and data are a very strong part of this. As I've highlighted before, the need for evidence-based and informed decisions. Prioritization is done according to national realities and needs. This can sometimes be difficult and sensitive, but is of course very necessary. The main element, of course, in this partnership is the leadership and the strengthening of the leadership of the national ministries of health. While putting them in the leading role, this is of course without denying the importance of other stakeholders such as civil society, community health workers, and so on. But there is a need for a strong Ministry of Health to lead a solid and sustainable health system which can benefit the entire population. This said, collaboration with others remains very important. Ministries of Finance, other ministries, civil societies, private sector, donors, and so on. It has to be a very collaborative process, as well as transparent and inclusive, of course, and giving a voice to all concerned. Next slide, please. So how is this partnership implemented? Well, we've seen in the previous presentation, and I think I've mentioned it already as well, there's a lot of diversity in UHC programs. The partnership is currently implemented in 20 countries, each with their own particular context, challenges and priorities. One of the most important guiding principles of the partnership since its very beginning has been that the activities need to be based on countries' individual needs, and roadmaps are elaborated in collaboration with them. Even though some countries in the partnership share similar priorities, I think it can be said that each country benefits from its own tailored approach. So how does this work in practical terms? Well, the partnership strengthens WHO in its core mandate and strengthens its country offices in their convening and brokering role, thus making them more capable of supporting the ministries of health and building their capacity for leadership. It's a different way of working, and also a somewhat new way of working. At least it was for us. But at the end of the day, I think we can all agree that a strong and well-equipped WHO is an absolute prerequisite to achieving universal health coverage. So in very practical terms, this means we are financing senior policy experts in a number of countries in the partnership to work directly with the ministries of health and other stakeholders in identifying and implementing the country's roadmaps. Alongside that, the partnership is also supporting WHO regional offices and HQ in these core functions. The partnership is implemented along the principles of IHP+ and respecting its 7 behaviors at global, regional and country level, even though the level of IHP+ implemented activities varies within each country. For example, in Cabo Verde, this was so far the main activity under the partnership, where the elaboration and implementation of a national compact has been the main activity and result so far, and has been supported by the highest level of government. Other priorities and entry points to the policy dialogue that have been recurrent in several countries include development of national health financing strategies and plans, M&E systems, annual reviews, situation analyses, and decentralization national plans and policies, for example. Next slide, please. So what have we achieved? I mean, after a full 3 years of implementation now, the partnership is actually seeing some strong results. Overall, there seems to be a much better understanding of the actual concept of UHC by the countries in the partnership. We see strengthened capacities of WHO country offices and of ministries of health. There's a reinforced harmonization and alignment of financial management systems, strengthened government mechanisms through working with a large variety of stakeholders. The partnership has also contributed to improved coordination of all stakeholders in the health sector in the countries where it is implemented. M&E systems have been strengthened. Plus, it serves as an excellent way of exchanging information and lessons learned between the countries in the partnership, but this actually also goes beyond. And one very notable result is that a large number of countries have actually approached WHO on their own and requested to be part of this partnership, which unfortunately for financial reasons is not always possible. And some of these countries have gone on and implemented similar activities and similar ways of working on their own, which I think is a great sign of success. In other countries, for example, the partnership has facilitated house-finding policy discussions, which led then to better integration of free healthcare policies within the overall health financing strategy. This was the case in Mali or in Burkina Faso. And here I have a concrete example, which I will actually come to on the next page. But there's quite a few. Although results take time and are not often very tangible, as I will explain when talking about the challenges, there are results, and after 3 years, we really have something to show. Some elements are present in several countries, such as I've said before, the decentralization, house financing, M&E. House financing can take many forms. In some countries, we start from scratch, trying to put in place some sort of health insurance systems, whereas in other countries, several fragmented systems covering different parts of the population already exist. And the goal here is to try and bring them together in the most efficient manner. Coordination among stakeholders, complementarity with other programs, and strict avoidance of duplication are key principles of this partnership. Next slide, please. Here I've used the famous universal health coverage cube. It's a slide that is also very often used by colleagues from WHO and talking about the partnership. Illustrating the cube with 3 examples from partnership countries. On the bottom left, where you talk about the population, so it's covered. The example of Vietnam, where the partnership has focused on hard-to-reach areas and as such hard-to-reach populations that have so far not had equitable access to the health services they need. Here too, of course, these are the poorest and most vulnerable, and in the case of Vietnam, often ethnic minorities, adding to the political sensitivity of certain components of UHC. In the middle, services and which services are covered, and this is now the example of Burkina Faso that I already hinted at. Burkina Faso has had a free MNCH program covering pregnant women and children up to 5, which has been in place and donor funded for quite a number of years. And the partnership is now contributing to expanding the services that are made available and to integrating the free MNCH component into a wider health financing strategy, which will provide health insurance to a larger part of the population, as well as covering more services. And then finally, the direct costs and the proportion of the costs covered. Out-of-pocket payments still remain a key component of how countries finance their UHC plans, particularly in the case for middle-income countries. And we've seen how this can be problematic. In Moldova, the partnership has studied out-of-pocket payments in relation to equitable access, as these do not always go hand in hand. So from these examples, we can see that the 3 blocks are actually strongly interlinked. Next slide, please. Now the challenges. a colleague from the World Bank has already touched upon this as well. We're talking here, the road towards UHC, it's not an easy one. The partnership has found a number of similar challenges. We're talking about new ways of working here, which are increasingly complex and need the right capacities to be implemented, but they also need the political will and commitment to be taken on, both from the donors and from the implementing countries. The investments are mainly in processes, and results are often not tangible and difficult to attribute, as well as taking time. The somewhat messy and nebulous nature of these sorts of investments do not make them the most attractive for donors. The EU has been, the Commission here has been a pioneer in starting this partnership with WHO, and they've managed to convince Luxembourg to join. It took us a while to analyze this, to reflect on it, since it is a very new way of working. The start was also quite slow, but I have to say now we are absolutely convinced of the added value, and I think it is certainly worth the time and patience that it took for this program this partnership to truly take off, and I will come back to this in a minute. We've also already touched upon potential conflict between expectations and actual result, and the need to balance this. These conflicts exist at different levels between the populations and the governments, between the implementing countries and WHO, between donors and WHO. So communication and transparency remain key elements. Next slide, please. Now let me briefly speak about the opportunities and the strong added value that this partnership has to offer. I mean, basically we provide highly flexible investments to WHO in areas that are usually unfunded or underfunded, and where, I said before, many donors are still reluctant. What we provide is targeted support for overarching and enabling processes, and that's contributing to sector-wide efforts towards UHC, addressing the entire health system. Accepting the risk of this sort of investment, it turns out that this flexible funding actually does yield significant impact. We've had a lot of feedback from the countries themselves, which has been tremendously positive. Once a year, WHO organizes an annual technical meeting where all the partners come together, so representatives from the countries in the partnership, mostly at MOH level. The WHO, the EU and Luxembourg as donors to exchange on activities, results, challenges, etc. It's a great opportunity, and this is where for countries to share lessons learned and experiences, and for us to hear that the partnership is really yielding results. I've previously mentioned that investing in WHO's key mandate and strengthening their capacities to support MOH is a worthwhile investment. We've spoken about bottom-up approaches, the importance of involving all stakeholders, the role of civil society and community health systems, etc. We've also seen that there are many aspects and thus many activities that fall under UHC. In order to ensure a sustainable response and system, these need to be brought together under one overarching umbrella, namely the national health policy. And this is necessary to ensure sustainability and guide the path towards UHC, and that is exactly where this partnership comes in. Next slide, please. The next slide basically just presents you the partnership website, where the countries can exchange through a special login feature, and which provides information to anyone who would like to see it. I think we've missed that slide, but that's okay. Why invest in this partnership? I think my presentation so far has made it very clear. The road towards UHC is messy. It requires innovative thinking and investments. It's slow, paved with stepping stones and changes in direction along the way. But that should not stop us from working towards UHC. The concept is clear, the goal is clear, the way that differs for each country and needs to be adapted along the way. It's not traditionally safe investments as such, but if we're serious about UHC, I think there's no way around it. And now my very last slide, the EU and Luxembourg. Next slide, please. What can we do more? I mean, we are highly invested in this partnership, and I'm happy to say here that both the EU and Luxembourg have committed to a new phase for 2016 to 18, with additional countries and added and budgets increased on both sides. So that shows how strong our commitment is. But to this day, we remain the only two donors to this partnership, and we need to seek out opportunities to showcase the added value of the partnership some more, and thus try and mobilize additional donors and resources so we can extend it to even more countries, since the demand is there. The momentum right now is very high. UHC and health system strengthening are more prominent than ever in the aftermath of Ebola and under the German leadership of the G7. Japan is taking over this priority as well. So opportunities are there to promote the partnership, and I speak on behalf of Luxembourg, but I hope and I'm sure that my colleagues from the EU and WHO will join me in saying that we will certainly make the best use of these and serve as leaders to get others to join us. The goal is not to create, again, many parallel UHC programs and mechanisms, as we have a tendency to do in the health sector. It is to work together in a coherent and collaborative manner towards our common goal of UHC. Thank you very much, and very sorry if I was a bit too long.
Thank you, Natasha and Ms. Gomez, for your presentation and for sharing and bringing, in addition to what was presented before, new evidence about what works, and to just link to your last slide and the challenge to bring on board other countries and other donors. Unfortunately, it is not the trend of the time to provide value for money when talking about processes, and rather than health outcomes. So it's great to see that European Commission, WHO, and Luxembourg invests in this. You clearly made it very clear the need to focus on policy dialogue, which depends on the strength of the Ministry of Health and its leadership. Push for a multi-stakeholder and an inclusive approach, which in essence reflects the rights-based approach, and which is common amongst European Union member states and the European Commission. And this brings me to the next speaker. And I would like to ask, within this context and the many initiatives that previous speaker referred to as well, UHC is high on the agenda. It is sometimes linked with health system strengthening, referring to the roadmap initiative by the German government and supported by Japan. But nevertheless, universal health coverage is high on the global agenda. And so it is good to re-emphasize that in the past 2 years nearly, in the run-up to the SDGs that have been agreed, that the European Union and European Commission has taken a very active role in support of universal health coverage and in support more broadly to a right-based comprehensive approach to health. And so I would like to invite Mr. Christopher Knauth to share with us some thoughts about the role that universal health coverage plays within the development cooperation of the European Commission, and to share as well reflections on the evidence that was brought to us both by the colleague from the World Bank as well as colleague from Luxembourg. Over to you.
Okay, thank you very much. I would like to start with apologies and a disclaimer. First of all, you had invited our Deputy Director General, Klaus Rüdischhauser. He was intending and confirmed he would come. It was only in the last moment that he had to decline and that he is sending me, so apologies from him and for that. And secondly, also, I mean, this event is about the role of European governments. I think we have just listened to the one and only representative of a European government who is with us today, which is Natasha. So as far as the role of European governments is concerned, I will refer to Council conclusions, which in a way are conclusions by European governments, because the Council is the European governments and not the Commission. So, and the third one I could have prepared also, and I did prepare more slides, but I somehow took it as an instruction to limit myself to one, which is the next one, please. That is the one and only slide I really prepared. So I want to, it's basically 6 points I would like to make. Universal health coverage is based on European values and enshrined in European policies. And there are several Council conclusions dating back which confirm this, and as I said, Council conclusions are conclusions by the governments of the member states. So we had Council conclusions by the Employment, Social Policy and Health and Consumer Affairs Council, which is very important to mention, about European values, which, and it said the health systems of the European Union are a central part of Europe's high levels of social protection and contribute to social cohesion and social justice, as well to sustainable development. The overarching values of universality, access to good quality care, equity and solidarity have been widely accepted in our work. And more concretely and more precisely and more relevant for us than the 2010 Council conclusions on global health, which say that the EU support shall ensure that the main components of health systems, health workforce, access to medicines, infrastructure, financing and management are effective enough to deliver universal coverage of basic quality care through a holistic and rights-based approach. I think this one quote brings it all together: the linkage to health system strengthening, the commitment to universal health coverage because of a rights-based approach to health and to access to health services. And more recently, and in the run-up to the New York this year, we had Council conclusions on the transformative agenda. And there it's very important to stress that in that Council conclusions, member states defined a transformative agenda as addressing the structural causes of poverty, inequality, climate change and environmental degradation, and that agenda should address the structural causes also of inequality. And this brings me to my next point. We are in a transitional phase, and let me put forward point 4, and now I am quoting Klaus Rüdischhauser, who would have been here if he had had the opportunity. I quote him, or I report what he said from another public meeting of the Friends of Europe here in Brussels a couple of weeks ago, where he said the European Commission is considering to rewrite our development cooperation policies. That is basically the European consensus, which dates back from 2005, and the Agenda for Change, which was a revamp, a quite recent revamp of our development policies. I put 2 question marks into this point because there is no official decision as yet, but Klaus Rüdischhauser publicly expressed his expectation that this is what is going to happen. And this is why I go now to the SDGs and the Addis Ababa Action Agenda on Health Financing, because we are really in between in a transitional phase towards something like new policies, and there's a very fundamental change of the SDGs as compared to the MDGs. They are global and universal. They concern our countries, middle-income countries, and the poorest countries. They cover the 3 dimensions of sustainable development, which are economic, ecological, and social. And they have an explicit focus on inequality, and in there, what we are talking about here, 3.8, the target on universal health coverage. I think this is very important. It's also important to mention, and I will come back to this in a moment or a bit later, is that there is some new language in the Addis Ababa agenda. They talk about equitable growth, which is something different from inclusive growth, because we have seen the success of the MDGs with inclusive growth. The poorest have been lifted over the $1.5 threshold, but at the same time, the richest have grown much more faster. So inclusive growth is not necessarily equitable, and the basic paradigm change which now we face if we are going to reformulate our development policies and if we are serious about inequality, is that inequality is something very different from pro-poor, targeting the poorest and making policies for the poorest. Inequalities concern the society as a whole, and so does universal health coverage. I mean, let me quote Joe Kutzin from a paper you also quote in your report. He says universal means universal. So we are really looking at the system as a whole and as societies in a whole when we talk about inequalities and when we talk about universal health coverage. Challenges we see is that if you look at the work which started with the 93 World Development Report of the World Bank, then you had the Commission on Macroeconomics and Health and a recent paper by Di McIntyre. There are some calculations which define the minimum cost of public health expenditure to guarantee a minimum package of services, which is currently estimated at $86. One may discuss about the validity of such figures in each and every country, but it gives an order of magnitude, and it is clear that there is a number of 60 countries which are far below this threshold, so they have no chance whatsoever to achieve universal health coverage until 2030 unless being substantially supported. And there are 40 countries where this is below $30, and a major concern, and here comes the role which is the title of this seminar, the role of the European governments. We have seen a reduction of EU health aid between 2011-13 and 2014 to 2020 by 28%, and the Commission has reduced the countries where it is present in the health sector from about 46 to 18. Member states have moved in parallel, so if there are countries where there is no support, no substantial financial and budget support to the health sector at all, they won't have any chance whatsoever to move towards universal health coverage. And as we were discussing at the seminar organized by the Luxembourg presidency recently, universal health coverage, and forget also about outbreak preparedness for events like Ebola. So this is something, a challenge European governments certainly have to face through joint programming, through harmonizing, through getting together when they design their development envelopes. There is the midterm review of the Commission EDF and DCI instruments, but each and every member state also should jointly look into which countries are left orphan from substantial financial support. Apart from that, and I note that the countries you have studied are mostly middle income and graduated countries, there is a question and a challenge, and taking into account that the SDG agenda is global and universal, there is a challenge for us also to consider how are we going to support those middle-income countries who are looking at Europe and who say we want to learn from your experience in moving towards universal health coverage. I have one success story to tell. The European Commission has done both, supporting South Africa on the supply and on the demand side, if I use the language of the report we are discussing today. On the supply side, the Commission has been supporting with a 120 million budget support the revitalization of primary health care in South Africa. On the demand side, through a dialogue program which involves different DGs, different sectors, and which is part of our support to middle-income countries and selected partners, we have supported a huge conference on the Green Paper of National Health Insurance in South Africa, which has also an important milestone in the process in South Africa in moving towards the white paper, which has come out recently and which sets the scene for a long-term perspective. I think it's 18 years or something in South Africa, where they want to move to universal health coverage. So there is very little, there is a lot of question marks in what I have been saying, because we are at a juncture where new policies are still to be decided whether they are going to be redefined, and then we will have to look how this redefinition looks like, what is to be taken for sure. Our Commissioner takes inequalities very seriously. He has set up a working group on inequalities in our DG, and there is a lot of focus now on the MDG 10. As far as the financing the domestic resource mobilization is concerned, I hope I mentioned that there is a strong emphasis in the financing for development Addis Ababa Action Agenda on progressive taxes and on reducing tax avoidance by big companies. I think this is something we need more. If we need more money and we talk about the sustainability of financing universal health coverage, we also need to know where this money comes from. So far, my short presentation as far as where we are or where we are not, where we might be going. Just a paar comments on the presentation. I note that when you talked about identification and in the book and in the you talk much more about targeting. There are huge costs of targeting the poorest, and my problem analysis of Vietnam is a bit different from Natasha's. I think there was a big problem that the government subsidized the poorest and the formal sector was covered, and there was a big gap in between of the near poorest. I have big question marks if it is a good idea, and to put it on a technical level, just we need better techniques and better science to better target and sort out the near poor from the poorest, or if we should rather see it not as a technical, but as a political issue and target the richest through progressive taxes and through redistributive and social security policies, which make universal coverage universal and not a targeted program to the poorest, which is the traditional thinking of pro-poor policies and is not the SDG thinking of addressing inequalities. My second point is I welcome very much that Natasha talked about social protection, because indeed this would also have to be seen in a broader support to partner countries in building up their social protection systems. And a final comment to Natasha, and I think this is a limitation we have experienced in our way of doing business. If we think about all these consequences which would come out of the SDG agenda, then just sector policy dialogue is not good enough. Very often, in our cases for the European Commission, we have some sector experts in our delegations. They go to the Ministry of Health and they conduct a sector policy dialogue. Now, with the partnership program Natasha was referring to, we want to have in those countries which we have selected WHO taking a lead in this process. But if we really think that we want governments to prioritize the health sector and the social determinants of health, if we really want to have them to have redistributive and progressive tax policies which are effectively addressing the challenges of inequality, then we need a much higher level political dialogue which would go beyond the margins of the health sector. So that were the last points, were personal points for and comments for discussion. As I said, on the Commission, I try to say what I could say at this stage. Thank you.
Thank you very much, Mr. Christopher Knauth. Thank you for listing the possibilities and already the at least political commitments taken by European governments in the run-up to the agreement of the SDGs. Indeed, despite its limitations of the Addis agenda, it's not only about what is in the course of the targets, but looking at what is the agreement to finance the Sustainable Development Agenda. And so there is certainly elements there that are worthwhile looking at or using for us as for advocacy, such as equitable growth. And I just want to invite Mr. Cotlier whether you wish to respond to one of the challenges that were outspoken, looking at the evidence that's been gathered and the experiences. I don't know whether you could share as well experiences where programs rolling out of UHC are not only targeting poor, but also from a redistributive policy point of view, are targeting the rich within those countries. So if possible, I would like to invite Mr. Cotlier to respond. We seem to have some technical challenges, so while Mr. Cotlier thinks about the question about reflection on the case of Vietnam and targeting poor versus rich and the needs for a redistribution policy, to invite our next panelist, Jean-Olivier Schmidt of GIZ, to join. And Mr. Schmidt, the previous speaker already touched upon what happens at national level and what developing partners, whether it's member states like Germany or Luxembourg or the Commission, can do. We've heard about policy dialogue with the sector policy dialogues or multi-stakeholder dialogues. Could you please share what have been your experiences, or what have been experiences from a implementing agency with regards to UHC, and whether you could share as well challenges and successes, and taking into account the initial presentation that was made by Mr. Cotlier.
Over to you.
Yeah, yes, hello, bonjour to everyone. Thanks to Tim and others for organizing this timely event on ex ante before the UHC day. Yesterday we had the International Day on Human Rights, so I think today as an interim day it's also a good opportunity to talk on universal health coverage, as universal health coverage is also something about human rights. And yeah, it has been said before already by Christopher that, but I would like to also to do a disclaimer that and to make clear that GIZ, I'm not as GIZ staff, I'm not talking on behalf of the German government, but on behalf of a technical agency that is implementing health programs, health and social protection programs in over 80 countries on behalf of the German government, but also on behalf of other donors, such as the Gates Foundation and European Commission. Nevertheless, because Germany has been mentioned a couple of times before, let me just say a few words on Germany's stance towards universal health coverage. Germany has invested a lot of efforts in the past 10 years at least, one could say, on to support universal health coverage internationally. And it has already under the last G8 presidency at that time in Heiligendamm, Germany has also made efforts to harmonize international efforts and on universal health coverage by launching the P4H, Providing for Health Partnership, that brings multilateral partners such as the World Bank and WHO and ILO together with bilateral partners. And I think this is already a very good platform that can be further expanded also in the SDG arena to create to create and give an example for something where we can work on UHC alliance, and we need to look how to find more synergies maybe with the already existing LUX and EU UHC partnership and WHO partnership. So I think there's still work for us to do to bring these different efforts together. As has been said already, UHC and health system strengthening has really come back strongly on Germany's development agenda, with our Chancellor taking the lead. She has spoken 4 times this year at international events on the need to strengthen health systems, and lastly launched the Healthy System, Healthy Lives initiative in New York at the occasion of the SDG launch, and this is currently in the operationalization. What it means basically, it is not another new initiative to supplement other partners' effort, but it is meant to reinvigorate WHO's lead role on health system strengthening, and thus in line also with what the Luxembourg partnership aims at strengthening the core role of WHO. Furthermore, Germany is investing substantially more funding, bilateral funding and multilateral funding into health system strengthening for the coming 3 years. Bilateral topping up only for health-related programs, mostly on health system strengthening, will be 600 million euro, plus in addition the investment into Gavi and the Global Fund, where we will also make a lot of efforts to link the work of these international institutions to health system strengthening, and to see that their efforts really actually increases, strengthen the health systems and doesn't undermine it. So this is in a nutshell where Germany is currently going to, and I hope it's been quite clear that Germany is taking this issue really very seriously. Now coming to GIZ's experiences in the field. yeah, I mean, we are working in over 80 countries worldwide on health systems, and also some of these countries overlap with those analyzed in the study by the World Bank, and some also overlap with, not surprisingly, with the countries where Luxembourg is working. And let me just say that we approach this from a capacity gap analysis framework by financial resources is one aspect, but we are not a bank, so we are not there to invest more finances, but we are there to develop capacities of a system. And we see the need to develop capacities at different levels. One is at the macro level, and this is where also the EU and Luxembourg efforts have come into. That is to create a policy space and to create the right framework, legal framework, policy framework to approach the issue of universal health coverage. Second level is to create the right institutions and organizations. It is not enough to have good policies in place, which is in some countries quite, I mean, some countries are quite advanced actually in having quite good policies in place, but they don't have the necessary institutions afterwards to implement these policies. And thirdly, finally, you need to have enough skill, manpower to work, to make these institutions work effectively. And let me also highlight here, I mean, I'm also heading not only health but also social protection division, so I'm clearly aware that sometimes we are a bit, when talking on UHC, and the need also for more human resources for universal health coverage, we miss a bit out. We usually tend to talk on the delivery side of human resources for universal health coverage. That's doctors, nurses, medical staff, etc. But we miss out sometimes on the need to have also the right institutions and right skill mix for those people who are administrating the system, particularly when it comes to new way of setting up systems with social health insurances. And in many countries there are hardly any health economists and social insurance experts at all. So this is just to highlight also the need to go into this slightly maybe less attractive area for donors. So at GIZ we are at supporting health financing strategies, the development of health financing strategies in an intersectoral way. That is, we try to have discussions not only with the Ministry of Health as the implementer often, but together to have these discussions together already with Ministry of Finance and together with Ministry of Social Affairs and or labor, depending on the context, and ideally to link it, like Christopher has mentioned it, to the Prime Minister's office, because this is something which requires usually a push from the very top to bring the different sectors together. These dialogues we are supporting, we also try to do this with all the relevant different partners together, such as the World Bank, WHO, and the other donors and development agents that are interested in this topic in the countries. Then secondly, on a more practical level, we support the setting up of social health insurance institutions with our long-standing experience by training actuarians, by designing the organizational setup of such social health insurances. And this is something we do in quite a number of countries. And thirdly, we finally train the people themselves by giving them exposure to European experiences of social health insurance, or by training medical staff. Yeah, like also Natasha has said, this is not always immediately intuitively to donors, so we are very glad that our ministry is supporting these processes which take a long time and which are also often very, very technical. And let me give you an example. For example, in India, which Daniel has mentioned, the program on health insurance for the poor, RSBY, as it is called, the RSBY was supported from the start strongly by GIZ and the World Bank for the creation of the IT platform that is behind the program. RSBY is a health insurance program for the poor. In the meantime, it has covered more than 1/3 of the target population, which is target population being 300 million in India, and 135 million people are covered now. And basically the recipients get a smart card on which the data is registered, and with this smart card the beneficiary is empowered to go to private or public providers to receive healthcare services free of charge, and this can be monitored at the national level. And so this program was rolled out very quickly by Indian standards, and but the reason it worked was really because there was a strong investment in the subserving IT platform going with this. We also, as GIZ, we also supporting, beyond this technical work, we're also supporting leadership work on universal health coverage, and we have rolled out a program on leadership for universal health coverage last year in 6 African countries. Also a work done closely together with the World Bank and with the World Health Organizations, where we brought together teams from the 6 different African countries, teams that had a mixed composure, not only Ministry of Health people, but also civil society representatives, which were fighting or had a role in universal health coverage in their country, which we had people from Ministry of Finance, we had implementers, and we had them discuss their joint understanding of universal health coverage and chart out action plans for the work at home. And this program was a 1-year program with 3 modules where basically people came together from time to time. And this program has been found very useful by the participants, so that we are now going to implement this program in Asian countries and then subsequently also in Francophone Africa, as there has been a lot of requests from Francophone countries to also participate in this program. Now, I would like to come back also to the presentation by Daniel and highlight some points which I noted down, but which in the meantime have also been partially addressed by the other speakers. But I would like to highlight again really the need to look at the quality of services, because I didn't see the word quality mentioned in the presentation at all. It is void, empty of any sense if we have universal health coverage without a factual quality of the services. And this is something which is which will take a lot of efforts and will also take a lot of time to achieve, and which is also rather difficult to monitor and to measure. For example, if you use the UHC cube as analytical framework to see whether a country has UHC or not, take for example Malawi. At the first glance it could look quite well within this cube, because as per law everyone has access to services, so it is really universal. There's a defined essential benefit package of health services, And there are actually out-of-pocket payments is fairly low, lower than the World Health standards. It's 8%. And for example, also skilled birth attendance is relatively high, around 70%. But in reality, you cannot really speak of universal health coverage because services are really very poor, if existent at all, and the quality of services are flagrant, and for example, maternal mortality is extremely high in this country despite the indicator that skilled birth attendance is 70%. So this again really a call for attention for the quality of services. A second point I would like to raise is the point of fiscal risks. I wouldn't be in many countries so much concerned or raise so much the attention to the issue of fiscal risks. I would rather like to highlight that there's a extreme underspending for health services, and in India, or let's say in all South Asian countries, spending on health, even despite new programs, is below 1% of GDP constantly. And I think there's simply a need to increase the spending in this context. And finally, one point I liked a lot from your presentation was the reference to the transformational aspect. I think this is something which goes, introducing UHC, if it works, is something that goes beyond really the health sector alone, but can create like a new social contract between the beneficiary and the state if they can see a clear linkage between their rights and entitlements to what they get. This can create a new dynamic, and people are empowered to ask more, the expectations rise, and I think this is good. So in Germany we have 125 years of experience with social health insurance, and expenditure has increased all the time and is still increasing, and yet our systems has withstood 2 world wars, a big financial crisis, and people are happy to get the services and are willing to invest into this sector. So with this, I would like to end, and thank you for your attention.
Thank you for your contributions and for your thoughts upon the report that was presented, and for sharing as well the experience, very rich experience in the different countries, and for example, you ended, so the need to, the capacity or potential of universal health coverage as a transformational agenda, but also the need to link the quality and availability of services beyond access and beyond what is being put on paper in policy decisions. I would like to go back to Mr. Daniel Kotlier and allow you to respond to some of the issues that were raised, and perhaps to 2 elements. One is in the different presentations that followed, the element or the need for a multi-stakeholder approach has been put forward, both in the case of the Luxembourg European Commission WHO partnerships, as well as the experiences that were raised afterwards. And so I was wondering whether in the 24 case studies, whether you came across some of the evidence where it was seen as a strength, or whether there was any weaknesses related to the use of a multi-stakeholder approach. And secondly, whether you could come back to the question of clarification around whether policies are effective when they are targeting poor, and what are the risks involved of having a poverty rather than redistribution approach. So over to you.
Thank you. Let me first thank the discussants. I thought this was a very rich set of comments, putting the questions and comments on related to UNICO in the context of what the European governments are doing. I thought was extremely insightful for me. I feel I've learned a lot about what the European governments are doing and some of the challenges they're facing thanks to this. Let me start perhaps by commenting on the 2 points suggested by Tim. Concerning the policies, concerning the question about poor versus equality, pro-poor versus pro-equality. Perhaps I should begin by saying, in the effort to make a succinct presentation, I skipped the slide I usually use to describe the methodology. And an important characteristic of this study is that this is a descriptive study. It does not aim to be prescriptive, and it is also not emphasizing, not looking at what the impact is. Now, in terms of description, what we're describing is 24 countries, and programs that are covering 1/3 of the population of the world today. We're trying to, we did want to make sure that we were not looking at any program that is expanding coverage. We wanted to make sure that these are programs that are not leaving the poor behind. And then what we're doing is we're describing how they operate. And so I don't think that most of the countries would think of their programs as targeted programs exclusively for the poor. The Chinese have a program for 800 million people. Indonesia has 200 million people in the program, and so on and so forth. In many countries, we're talking about 40–50% of the population. But also there's often a couple of misconceptions, I think. One of which has to do with whether what we're talking about is what these programs are aiming to do in the long term, or if what we're trying to understand is what these countries are doing on their day-to-day. In order to get to the long term, what is the next step they need to take? And in the study, we emphasize the use, and I noticed that Natasha picked on this. We emphasize that what we observe countries doing is very often using stepping stones. They are aware that the stepping stone is not the end all. It's not the final system they want, and often does not provide all the equity they would like to provide, but it's a step that countries think is needed. Countries often find themselves in the impossibility of jumping towards directly towards the final system they want. And so what the study did was look at what are the instruments, what are the benefits, the potential benefits, and what are the risks of and what are the risks involved in taking these stepping stones. The second thing I'd like to emphasize is that often there is a perception that that these countries are creating poor systems for the poor, which then risk becoming poor systems. And in all cases, it's important to understand that the starting point is not zero. It's not a tabula rasa. The starting point is a highly fragmented health system. And what the programs we're analyzing are trying to do is the supply side programs are trying to invariably improve on the quality of the systems that are already serving the poor or the lower income population. And in the case of the demand side programs, what they're doing is they're trying to help finance, help overcome the barriers that are stopping the poor from making use of the existing systems or from making use of the better niches in existing systems. So these are not creating segmentation. These are programs that are invariably reducing the gaps and reducing segmentation. Do they offer immediate equality? No, they don't. But I think it's in this context that these policies are not just pro-poor, but they aim to be pro-equitable. And again, what the study is doing is making a description of what countries are doing. Obviously, one can criticize countries for what they're doing, but I think it's very important to at least first understand in detail what they're doing and also understand why they're doing it. And I think that was one of the contributions, the main contributions we wanted to offer with the study. Understand why policymakers are making the type of decisions they are making. I wasn't sure, Tim, what is meant by multi-stakeholders. So perhaps I'll postpone that until that can be clarified. But having the floor, I wanted to perhaps make a couple more comments on some of the very rich discussion points. I wanted to perhaps go back to Natasha's presentation, and I really liked these examples of the way she's conceptualizing their programs in Vietnam and Burkina Faso and Moldova. I suspect there will be a lot to learn from the angle she described in relation to this. With regards to some of the comments by Jean Olivier regarding regarding quality of services, I think you're completely right in what you say. If there's no quality of services, you're not going to be able to improve health outcomes. What seems to be happening, however, is that in the countries that are taking the demand side route, there seems to be an implicit expectation that there's going to be perhaps 3 steps towards effective coverage. The first of which is simply the nominal coverage, is the registration of people as being potentially beneficiaries of a certain program. And the idea, I guess, the theory of change involved is that once you make that promise, that is going to force the different forces that need to participate for real coverage to take place, by simply contact at the level of healthcare to take place. And only at that point can you really begin to operate in terms of improving the effective coverage. I think that we see a couple of examples of this happening. One is when the team doing the UNICO study in Indonesia came out very strongly emphasizing that there was a lot of implicit rationing in Indonesia, that a very generous program had a generous benefit package had been offered, but most of the clinics and hospitals, particularly in rural areas, were not capable of providing these benefits. This led to a request by the government to carry out a facility survey to measure effectively the gaps, and this has now led to a very large program of investment in improving the capacity of these establishments.
Thank you, Daniel. I am going to limit your contribution if that is fine for you, because we have just taken into account the time limit. We have reached 4 o'clock or 10 o'clock your time. So if you allow me, I will start closing this session by thanking you for your presentation and your responses to the questions that were raised. Thanking the panelists for joining physically and online for this panel debate, and thank both the rich evidence that's been brought together, a European perspective and a World Bank perspective, that has shown there is no one-size-fits-all for UHC, but we know what works better than what doesn't, and it's up to us now to use it for the many policies that are being drafted, as was referred to. We are in a transition, and allow me to say that both Action for Global Health and Global Health Councils and many other civil society networks, we are following this closely, this transition, and we will try to input and involve all of you. So thank you once more, and looking forward to see you join a following call. All the best. Bye-bye.
Bye-bye.